Hi, I'm Reid, Executive Director of the National Lighting Bureau, and I am joined by Dr. Bernard Camins, the Medical Director for Infection Prevention for Mount Sinai System. This is part of our Let's Talk About Light and Health series, a collaboration between the National Lighting Bureau and Mount Sinai's Light and Health Research Center. Today's session, Beyond the Visible, UV Disinfection, and we're sponsored by Current. Again, Dr. Camins, welcome, and thank you for joining us.
Thank you, Randy. It's a pleasure to be here with you.
Well, we're happy to have you, and tell our audience a little bit about your role as head of infection prevention at Mount Sinai.
So as the medical director for infection prevention at the Mount Sinai Health System, my main task is actually to make sure that we have standards and procedures in place that prevents the occurrence of healthcare associated infection within our hospitals. The main goal of my role as the medical director for infection prevention for the Mount Sinai Health System is to actually make sure that we have standards and policies in place that makes every effort to prevent healthcare associated infections among patients. They entrust their lives and their care to us. So it's really important that when they come to the hospital, they don't end up with a healthcare associated infection. Okay. So that is our main goal, is patient safety, along with also preventing adverse outcomes, right? A secondary goal would be to actually also be financial, meaning when patients avoid infections, then that means their length of stay is shorter, there are less readmissions, and again, they go back to their normal lives as soon as possible.
Sure. And there are many techniques to prevent pathogens in hospitals. What role do UV technologies play?
Well, at this point, the role of UV technology is actually just an adjunct, right? So what happens, we have set up policies when surfaces should be disinfected, especially when patients get discharged from the hospital. We do a terminal disinfection of the room, the patient room, and that while we depend so much on on our environmental services colleagues in making sure that each surface is disinfected adequately, UV light actually comes in and potentially just augments that method, right? Meaning for some areas that were not completely where there was potential still contamination that existed, the UV light then can make sure that that is done deeply, or at least is, as an adjunct to it. So
okay, so it's really additive to the chemicals, and they are chemicals that are being used, correct?
Right. We are using EPA registered disinfectants that's approved for use in the hospital, in the healthcare setting.
Okay. So there are different strategies for airborne pathogens like coronavirus and surface pathogens like E. coli. Do you see some confusion in the medical community on which strategy works where?
That is really a good question, because as the same in the medical community or even in public, right? They actually assume that if you use UV light, it'll work the same way in disinfecting the air or disinfecting surfaces. But the primary use of UV light technology in healthcare right now is actually to disinfect surfaces. While potentially we could use it to disinfect air as well, we actually primarily depend on ventilation, such as negative pressure. So having a room that is negative pressure and then the air being filtered by HEPA filters as the way to disinfect the air. So in the current use of UV technology in the healthcare world is primarily just to disinfect surfaces.
Okay, but to understand, when you talk about using the HVAC and the pressure and the HEPA filters, why not put a UV filter in that ductwork? Again, it would be additive to help clean the air.
Sure, it is potential, but we probably need some more studies to show that it makes a difference, right? So I think additional studies are needed to actually see if adding UV light in that air duct is necessary, or is the HEPA filter adequate?
Okay. Well, you may be getting a few phone calls from some salespeople right after this. Dr. Camins, what are some of the limitations you see to UV technology in preventing infections?
Yeah, so the current UV technology, and again, I look forward to a day where we actually identify UV devices that is safe um, uh, uh, for humans to be exposed to, right? So in this current situation, all the UV devices that we are using currently are where only the room has to be empty before the UV light is turned on, right? To actually disinfect the surfaces. And while um, uh, and so while there are some upcoming technology may be great where we can actually do continuous disinfection, that is really what I'm really excited about.
Okay, well, that technology does exist and people are doing it now. Have you seen those studies and do you plan to implement this at some point soon?
Well, so Randy, the issue here is that you really have to show, right? In healthcare, I think one of the things you have to show that you actually have to show it improves outcomes, and not just saying that it reduces bacterial burden, right? So the bar is set a little higher in healthcare situations where, because we have plenty of interventions where it was shown to work in the laboratory setting, but it turns out in the real life setting, it didn't lead to a decrease in healthcare associated infection rates. I hope that is clear, right? Because again, while we could do a lot of studies in the lab or in an in vitro situation, they may not apply in vivo. While I am very excited, mind you, I think that these are all worth investigating and to see if the additional cost is worth doing, right? So.
Well, I'll just add my 2 cents. I think your point is very well taken because what I do is I see a lot of research out there, but with someone of Mount Sinai's size and scope, you to implement this across your entire network of properties, you have to see some proof to know if there is the cost justification for it. So I do understand that.
Yeah, and I appreciate that. Again, I'm approaching this with an open mind that I think that we actually have to have really good data. Otherwise, I can't justify it for our, because it's a matter of choosing of what we should cut, right? Or if there are any cuts need to be made, or if there are additional investment, we actually have to show that there is a return on our investment.
With the UV that you're using now, where the rooms have to be unoccupied, do you worry about injury? Do you worry about mistakes?
Sure. And so that's why when we pick a UV device, we make sure that there are some safeguards, right? Meaning that there is an automatic switch if detects motion, right? There should be motion sensors, and that we also put signs outside the door to make sure that no one walks into the door while the UV light is on. So all those safeguards are put in. So let me go back. I mean, I guess I don't want to make this where I'm challenging people, especially the air. The reason I'm saying, Randy, about that is that it's not a generally accepted standard, right? So there's a difference between saying, well, if a hospital decides decided they want to do that. And there are certainly, as you pointed out, there's a higher bar to meet, right? While I do think that UV light in the air handling system helps because it prevents mold from growing, it's not an accepted standard yet, right? It's not an ASHI recommendation or infection prevention or SHEA or APIC recommendation, because the studies aren't there yet. Mind you, you don't need patient-related patient outcomes data for that part. I think you just need to show that you replace less filters, right? That's yeah. So potentially you can make that argument that installing UV lights within air handlers are potentially advantageous just for the sake of not wasting money on more filters, right? And preventing mold from building up.
Okay. And then if you do get the cost justification from the filters, then if it does help clean the air and you have less, then that's an additive, that's a benefit.
Right. And just to clarify what I'm saying as well is that we also have to work with our colleagues who are in the filter industry, right? Where they would then have to update their recommendations instead of time dependent. It should be dependent on how contaminated they are, right? Because if they still have this time dependent recommendations to change filters, then even if you reduce the burden, you still have to change the filter based on their recommendation.
Okay, I see that. So our industry should also be working with the filter industry to have a little collaboration and help each other.
Agreed. I think I'm all for it because it does lead to even less waste, right? We're in an era now where we should worry about how much waste, right? So by creating less waste, less filters that are being discarded means then less that has to go into landfills.
Sure. All right, before we open the floor to questions, do you have any closing comments?
I am really excited about all the advancement in UV technology. And so I am open to, exchange in ideas. And in fact, I am collaborating with two people in particular, Mark Reid and Richard Vincent, in continuing to study the potential advantages of UV light.
All right, very good. Okay, well, Dr. Camins, thank you so much, and please stick around. We're going to open the floor for questions.
Okay.
Thank you very much for joining us today, and we will now open the floor to questions. Please type your question in the Q&A section, and we want to be sure and thank our sponsor, Current, for making this happen. While we're waiting on your questions, I want to remind the audience that our next session will be 31 October. Let's Get Deep, Lighting in Submarines, and that'll be at noon Eastern. Our producer, Allison Thayer, is on vacation this week, and Jennifer Bronze is taking her place. So, Jennifer, I will turn it over to you, and you can help with the questions.
Thank you, Randy. And thank you, Dr. Camins, for sharing your perspectives here with disinfection. We do have a question from Timothy Stevens about surgical situations. Timothy, you want to ask your question?
Thank you for taking my question. Yes, concerning UV disinfection in surgical situations, we were looking at the possibility of a continuous disinfection situation where UVA light might be able to be used through the surgery as opposed to before and then after, as in UV, the typical UVC situation.
Yeah, so I think that's a really good question, Timothy, and I think it's worth studying, right? Because right now, unfortunately, the only option for surgical suites, which I know some companies have installed them, are UVC. And so even in that situation, you would have to empty the entire room. And depending on what you're trying to disinfect, are you trying to get you want to have a sporocidal treatment or just a regular treatment? It does take a while and you have to empty the room. And so for the most part, it happens at the end of the day. And so I think it's worth looking into this situation and to see, while it won't really replace manual disinfection, you still have to do it, but I think it potentially can make manual disinfection easier, considering then if it decreases the bioburden, right? So certainly this is something that Mark and I are actually collaborating on, and so hopefully there will be more data on this. Certainly not in a surgical room, but probably in other situations. So,
yeah. So, what is the viable particle of concern in a surgical suite? Is it all those things, spores and bacteria and viruses, or specifically, is it more one or another?
It's actually more bacterial, right? So in the surgical suite, now you could potentially have hepatitis B and hepatitis C contamination, but in that situation, it's less of an issue, but more of bacteria in that situation, and not even spore-forming bacteria, like such as C. diff. So.
We have a question from Greg Hansen that's related to what Timothy was just asking.
So I was curious to know what exact frequencies of UV light you were using and what was the delivery method in terms of luminaires.
So as far, you're talking about currently, right? Our current practice is that we actually have UVC 254 nanometer, the typical ones, the robots as they call it. All our hospitals have them. We use them not for every single hospital discharge, but discharge of patients with C. diff or Candida auris, which are more hardier organisms. So, so they are in a way bulky. We have to, deliver them to each room, and they do take time, but it's worth it. And especially in the situation for C. diff. Mind you, it's not standard of care, right? Not all health systems are using them. Potentially other stationary UVC treatments can also occur if you install them in the rooms without having to move them, but we have not gone into that route yet. So,
all right, we have another question from Dr. Mark Ray. Mark, would you like to ask your question?
So Bernard, one thing that I'm not altogether clear on is how do healthcare-associated infections spread? Is there a route that UV would be particularly useful for or not useful for?
So one of the most common, that's actually a good question, Mark, is, I think even healthcare workers need to be educated in how it is spread. So the most common way is actually through healthcare workers' hands, right? So how does a resistant organism get from one patient to the other? The most common is actually from healthcare workers' hands. So meaning if they touch a patient or touch a surface or something in the room where a patient who has a resistant bacteria who may be harboring that, and they touch it and they go to another patient without doing hand hygiene in between. So that certainly can happen. And that's probably the most common cause or most common way of spreading resistant bacteria. The other situation would be that you have somebody who has a resistant bacteria and they get discharged from the hospital and there was a lapse in environmental disinfection, right? Say, that the room wasn't adequately disinfected with surface disinfectant, and then that room then can be contaminated, and so the next patient potentially then can be exposed to it. Other ways, at least associated with outbreaks, would be from devices. So again, having devices that are not thoroughly disinfected, or so they could be IV poles or blood pressure cuffs, maybe blood pressure machines, or in some, outbreaks that have been published, really endoscopes, right? So GI scopes and ENT scopes, those are potentially other avenues for how resistant bacteria can be spread.
Just so to follow up on that, then where do you think the biggest bang for your buck would come from a UV intervention?
So I think the best scenario would be to have a continuous exposure of surfaces, right? So I don't worry about shadows, because how does bacteria get into behind the TV, right? It's really hard for it to get there, or potentially even under the bed. That's not, so we worry about surfaces that are accessible to patients and healthcare workers. So again, the best bang for our buck is either currently at the end of a disinfection routine done by EVS, or but if we can do it continuously, so when they come and clean the room, then potentially the room is not as contaminated. So those are potential ways of reducing bioburden.
I had a question, Dr. Camins, about how monkeypox is that affecting how Mount Sinai's operations and cleaning procedures, new diseases like this, are they affecting how Mount Sinai's discharging patients?
That's a really good question. I think every time we have a new pathogen, right, in this situation, a virus, we always want to see how effective is the usual decontamination techniques are, right? So as far as monkeypox is concerned, the good news is that it is a very sensitive virus that the usual disinfectants can actually eliminate it, or can disinfect surfaces contaminated with monkeypox. Same thing with SARS-CoV-2, right? The virus that causes COVID-19. But a more recent pathogen, a fungal pathogen called Candida auris, is very hardy, and that we have to actually use bleach nowadays, only because while there are more and more data now that potentially some non-sporicidal disinfectants are effective, at least in the beginning, we had to start with a sporicidal disinfectant. But you're right, for every single new pathogen that is discovered, that's being transmitted among patients, then we actually have to figure out which disinfectant, or in this case, even UV light, right? If they actually are sensitive to UV as well. So,
Dr. Camins, I want to thank you for this. It was a very interesting discussion, and I know that I sure learned a lot. Jennifer, I thank you for pitching in with Allison, and then we want to thank our audience. And just a reminder, this will be available tomorrow on YouTube at the NLB website. You can find it there. And then please join us on 31 October at noon Eastern. Let's get deep.
Thank you very much. And I look forward to the session of October 31st.
All right. Sounds good. Thank you all.